Good morning, good afternoon, good evening, and good night, wherever you may happen to find yourself on this day. We thank you for joining us for Season 5, Episode 22 of Doc Talks with Dr. Forrest Tennant and friends. Unfortunately, Dr. Tennant is unable to be with us this evening. Everything is okay. He's fine. He's just not going to be able to join us tonight. And so we are going to do what we can do. And Pat has a wonderful presentation already started for us. And so, Pat, I'll go ahead and turn it over to you and let you get started on that. And then if we have questions afterwards, we can do what we do.
Thank you so much, Jamie. And again, welcome everyone. I know it's a beginning of a holiday weekend, and it's wonderful that you've taken the time to join us this evening for some information on influencing your state medical boards, which you all know is desperately needed. I would like to say before I get started that I won't have the slides up tonight. Jamie and I are going to try a little bit different with me just having the slides in front of me, but I will make the slides available both on DocTalk and I'll have Red put them out to the national campaign emails. If for some reason you want them and you don't see them, please text me or message me on Facebook and I will make sure you get a copy. So don't feel like you have to take notes. If you want to, that's great, but you certainly don't need to. So again, this is the third in a series of our advocating lessons. And if you've missed the second one or the first one, all of the information is on DocTalks. We're pinning the information to the feature section at the top of the page. So it should be easy for you to find. But again, don't hesitate to ask Jamie or myself if you have problems finding information that you would like. The last two meetings, we went very quickly and we did not have a time for questions. And I do want to remedy that tonight. I'm going to remedy it in two ways. One is I've gone to the chat from the last two, picked up some questions, which I'll answer directly. And more importantly, I've left time so when we get to the end, I want folks to feel free, to raise their hand or let Jamie know that you have questions or input that you'd like to make. We have the time tonight to do that, so make it advantageous to yourself. If you found that you have questions on things or things aren't gelling, please feel free to speak up. I do want to say just for a moment that Dr. Tennant did just want us to know one important thing. He very much realizes that the guidelines are a fundamental foundation to everything we do with the boards, but it's not just about the guidelines. It's about changing the heart and mind of the people on the boards. And Dr. Tennant would like us to remember that yes, we're going to be talking about guidelines, but that's not the end goal. The end goal is really to change the mindset of the people on the boards and how difficult that can be. With that in mind, and I hope I don't put him on the limelight too much, only as much as needed. I'm going to read for you briefly from a letter that Monty Goddard has written to the board, and it strikes directly to my point and Dr. Tennant's point about hitting to them the true meaning of why they are there and what they should be doing for this. And he, at the end of his letter, puts two quotes. One is from Pope Francis, and it writes, and it quote is, "It is important to give voice to the unheard suffering of those who in illness are left alone, lacking financial and moral support, easily exposed to despair and loss of faith, as can happen to those with fibromyalgia and chronic pain." So that was Pope Francis. Then he puts another quote from Dr. Albert Schweitzer. "Think occasionally of the suffering of which you spare yourself the sight. You don't look. No one may shut his eyes to think the pain, which is therefore not visible to him, is non-existent." So what Monty has done here is called upon whatever humanity is left in these board members to pay attention, to listen to what we are saying. And I want to let you know that Monty's letter is available, will be available, and if people want to use it as a template or to see what you might write to your board, um, I know he would not mind sharing it. But speak from the heart when you write to the board. They need to hear what you are feeling, what we are feeling, what we are going through. It's really not just about the guidelines. And having said that, it's not just about the guidelines. I am thrilled. I put out a request for people to look up their guidelines. And I know you can't read names, it's okay. We got 25 names. 25 of you took the time to look up your guidelines, to look at your, I'm flabbergasted with everything everyone has to do with the pain that you're suffering, with the day-to-day troubles that you have. This was beyond expectation, right, Jamie? Beyond expectation. So I am thrilled. And they're from many different states, which we'll talk about in a minute. And we even got some comments on there. Janine, thank you, Janine from Ohio writes, my board has 9 doctors on board. So see, as we look at our boards, we're learning how different. Remember, Dr. Tennant was saying, well, the California board doesn't have that many doctors, but they're all, which is true. And what he said is absolutely valid, but every board is different. So that's why, that's the importance of me having you assess your board. I can't tell you what your board is like. The only board I really know about is California and Montana because we know it's so bad, and Maine because it's non-existent. Well, what they're doing is non-existent. But for the rest of you, it's absolutely critical that you look to see how many doctors do you have on your board? What do the guidelines look like? And we'll talk about that a little more. So if you didn't get your name, where did I get these names? I got the names from chat. So if you didn't get your name on here, I'm going to post this. This will be on DocToks. On DocToks, look for your name. If your name isn't here, just put a little note in DocToks, or better yet, put a note right here in chat that you did look up your guidelines, and I'll make sure you get on the list. So thank you, all of you who did that. Very, very important, and I appreciate it very much. Not too late to get your name on there. Now, with that information, I know you can't see this either, but I'll describe it. What I did was I took your names and your information and I put it on the Pat Irving infamous table. If it's important enough, it has to go in a grid. So we have states going down this way. We have the names of people who are, I'll call them seasoned advocates who might help you. And then we have the names of all of you who have volunteered to work on with your state. And it's interesting, it groups. There are 8 people in Alabama. Let me just give you an example. So we have Patrick, Brandon, Allison, Annie, Pamela, Karen, Jean, and Teresa. So some states are like overflowing, and this is great. We're going to talk about how do you work together? How do you contact each other? Um, and then California has quite a few. California has obviously Monty, Kristen, Pat, but it has Shelley, Teresa, Leanne, Scott, right? So nice groups of people to work. And for those of you who are by yourself, you are not by yourself. We will help you out. For example, Idaho has Eric and Illinois has Dr. Brian Lynch. Just one person in those states, and that's okay because we'll make sure that you have somebody to talk you through what the next steps are. Okay. I'm going to put this on DocToks as well. Please do me a favor. If for any reason, you don't have to tell me why, if for any reason you don't want your name on this list, just put a comment, it goes away. I will be sharing this only with National Campaign to Protect People in Pain, but you might say, you know what? I don't want my name outside of DocToks, and I will respect that. So please let me know if you want your name taken off the list. It's got all kinds of great information. If your state has a state bill, I put that information on here. I put the information about your guidelines on here. So it's going to give you a nice head start and you can see who else will be working with you. So I hope that helps. Um, Good.
Hey, Pat,
What? Yes,
um,
Mark, go.
I'm going to say something edgy because that's where
Okay,
I'm at today.
you go.
If you're watching this and participating in this group, which is a group for advocacy, and you don't want your name mentioned, I invite you to find another group to hang out in.
Ooh, that is edgy. Ooh,
Yeah, thanks.
okay.
That's it.
All right. Thank you, Dr. Ibsen. Heard. Documented. Questions that were asked. All right. So these I got from chat. Now, some of these questions might sound edgy, and I don't want you to take them as edgy. Every question I'm going to read is a legitimate question. So you might say, why did the person say that? That's not very nice. But that was not the intent of their question. People are asking legitimate questions. So here they are. Shouldn't someone other than the boards be doing guidelines? If the California guidelines are so good, why are California patients still struggling? That is a valid question. Edgy, but valid. Why does any of this matter if the DEA is still active? Darn good question. How can people unite in a particular state? Can people already established or more seasoned in states help the new people? Yes, and yes, and we'll talk more about that. And then again, these are just the 4 I wrote down from chat. More time at the end for you to add questions. We'll wait till the end. So let me tackle those 4 questions. So the first one is, shouldn't somebody other than the board be doing the guidelines? You would hope there would be other groups, but in fact, interestingly, the board is the legitimate organization to be stating what physicians should and should not be doing with their licenses. They license physicians. Dr. Ibsen, jump in here anytime. They license physicians, they discipline physicians, and they have influence over individual physician practices. It is their charter. So we can't give this job to somebody else. We wish that sometimes that we could, but it is the boards that have the correct responsibility for licensing physicians. It is the state medical boards. Not only that, their missions are to, and I'm going to read you the mission for 4 different places. The California mission is to protect healthcare consumers and prevent harm through proper licensing and regulation of physicians and surgeons. They also write, and to promote access to quality of care. So that's their mission, right? The Board of Montana, you may roll your eyes, Dr. Ibsen, says it is to protect the health and safety and well-being of Montana citizens. We're going to hold them to that. That is what their mission statement says, to protect the health, safety, and well-being of Montana citizens. The Board of Alabama, what does it say? It says our joint mission is to protect the health and safety of Alabama patients. So this is the mission of these organizations. That is why they are there. Right? And we're going to hold them to it. Of interest, Maine has no mission statement. Do you find that interesting? I could not find a mission statement for Maine. Are we surprised? Probably not. So to answer that question, yes, it is the board that should be doing the guidelines, and we need to help them to do it correctly. The next question essentially was, why is California still having problems? And I'm going to switch that a little bit to, are guidelines enough to protect patients? Right? If California has such good guidelines, why are we still struggling? A lot of reasons. First of all, the boards have regulatory power over individual physicians, their license, their ability to practice, etc. They do not have authority over groups. So Shelley, for example, they don't, we've talked about this before, they do not have regulatory power over Kaiser Permanente. The Medical Board of California cannot say, Kaiser, Northern California, you are mistreating patients in an inhumane way. You must stop. They do not have that regulatory power, but they have power of influence, and they certainly can and should hold these insurers accountable. And when Monty and Kristen and I go on to the California board, we remind them clearly of that fact, that that is their responsibility, and working with them to get that. Now, part of the problem is, and this is the second answer, is the guidelines are administered by human beings, and they have prejudices and they have bias.
I'm not buying that.
They do. They do have
Well, no,
bias.
no, they do, but wouldn't let them off the hook
Oh,
because of
no,
those
we're not letting them
frailties.
off the hook.
No.
Nope, nope. And in fact, Dr. Ibsen, what we're working with right now is we realize that the state of California and the board realizes that their culture back from many years ago when they did the autopsy project was anti-pain patient. And so there's still that bias, and that bias exists in the people that are evaluating physicians. It is when you go to get interviewed, you may find that that information is still there, and it takes time to change a culture. Changing a culture does not happen overnight. Now, I'm not making excuses for California, but the good news is major players on the board of California have admitted, yes, we need a culture change. We need to come around. We need to make this change. We know. Matter of fact, it says in their guidelines, actually, that they realize that harm was done to patients and we need to come forward. If you read their preface of their guidelines, but they can't change it overnight either. And so we're helping them, reminding them every time we talk to them, yes, this is where you need to go. There are obviously, what else is happening in California? There's obviously forces outside the board that sneak in. We talked about the DEA, the FDA, all the alphabet soup, the CDC. So as powerful as the board and influential as the board is, yes, they are also competing with other voices, other narratives that they're trying to work on. To me, it just means that working with the board is never black and white. It's not suddenly bad, it's not suddenly good. It's an ongoing fight. And sometimes you make huge strides and you feel just elated with what you think you've accomplished. And then you turn around the next time and somebody on the board says something that you just want to cringe. And that's part of the process. And we're going to support each other so we don't give up. We do not want to give up. And I want you all to feel free when you've had a bad week and you get some statement back from the board that you think, oh my gosh, we're never going to fix it. Just talk about it with the group, because we can change them. It's going to take time, but we can change them.
Pat, if you don't mind, Monty had a quick.
Oh, Monty, please jump in. I didn't see Monty.
Here you go.
The only thing that I would add to Pat's explanation about California has good guidelines, why does it still so bad in California? You know, we all are aware the big kahuna on the block is the DEA. And the doctors are still afraid of the DEA.
Yeah.
When you go back to what we've been attempting to control, and we're starting at the beginning with the end in mind, we need to get the medical board on our side. And in California, I believe, and I can give many reasons why, the medical board is on our side. What they have failed to do, which they recognized they needed to do throughout the year and a half to 2 years that we worked through the process on developing their new guidelines, was that once those guidelines were published, that was not the end. They needed to, and they committed to over and over an aggressive rollout of those guidelines, webinars, training to try and convince California physicians that at least the medical board won't be all over their case if they comply with their guidelines, which are pretty darn good. There are no MME limits in them. They are offering, they acknowledge that there are patients out there that don't fit into normal guidelines, that a physician specifically states that a physician can prescribe the required amount of medication that it takes to treat the patient's condition. That's all really, really good stuff. But the problem is the physicians in California still don't trust the medical board. They are fearful of the DEA. So the published guidelines were not the panacea. Some were hoping they would be. Some of us knew they wouldn't be. But they are a great step forward. And if we can get enough medical boards across the country to follow the lead of what California has done, then we might have some leverage with the feds. That's what keeps me going. I'll shut up now.
Oh, Monty, thank you so much. And a matter of fact, did you read my next slide, Monty? That's cheating. So
I don't
my
think we
next
need to
slide
have any.
was, does any
I
of
don't
this
think
matter if the
I
DEA
don't
is
think we
still
should have
active?
any fear of the DEA. I mean, our group, you were within the North. I think Mark Ibsen. What we've
Who's
done
talking?
is we put out a
Oh,
series of articles, and what we've done is we have the DEA. First of all, law enforcement has no business dictating the practice of medicine. Uh, and that's clear from what Congress has passed. Richard Lawhorn wrote a piece on that, and they've sent a letter. We have 3 letters from the DEA saying that they do not dictate the size, the amount, or the dosage form of what a physician's prescribed. That came from Thomas Provenzano. We published that information. The problem is, and I think all of us is media has drank the Kool-Aid. They have systematically ignored it.
They were
I've had a
paid to also.
yeah, yeah, and they have I mean they've carried this false narrative, and we also have what I call academic jealousy. A lot of these media guys are more than happy to see the big bad doctor who knew it all and that sort of get his butt kicked in courtrooms. And it's easy to call us drug dealers and white coats and those sort of things. And the board is I think Mark will tell you, Ibsen will tell you, is that it's controlled by lawyers. These lawyers know nothing about medicine, and somehow they're allowed to dictate the practice of medicine. And the final thing is that culture of why this happens is because doctors, physicians, pharmacists like myself, and we're goody two shoe guys. We never got in any trouble with law enforcement. We follow the rules, and we expect that when you follow the rules and you present the truth, that you will prevail. And that's not happening. I mean, it's when they get to court, it's win at all costs, and it's about our assets. So we chose to fight, and I really appreciate this seminar, because it and this discussion that we have here. But if you ask guys like Dr. Ibsen, you have to be a strong advocate and you have to fight every day. As we say, we leave no stone unturned, no subject untouched, no unkicked. I'll leave that alone.
exactly.
Thank you,
Exactly.
Doctor. We appreciate
And
you.
And
Thank you.
yes, and I have a favor. If when folks do jump in to talk, could you please speak out your name because it doesn't always show up, and just so we know
It is Norman
who's
Clement.
talking. Some
It's
names,
Norman
some
Clement.
people I recognize. Yeah.
Okay, it's
That was
Norman
me,
Clement. I'm a
Brandon.
pharmacist and a dentist, and I write the blog. We write the blog. I'll say not I. We write the blog. You are within the norms.com.
Thank you. Thank you very much. So I am going to go ahead to that slide that Monty had secret info. No, no, he was speaking from what he knew. But all joking aside, to the slide that has to do with, it doesn't matter if the DEA is out there. And it goes to what Monty was saying. When patients put in a complaint with the board, their care, their case is evaluated, and here it comes, against the standard of care. And the standard of care is made up of many different things, one of which is guidelines. One piece of it is guidelines. So when Shelley's case goes forward, they're going to look at the guidelines that were active when Shelley had her forced taper. And she's in good standing because the guidelines are very supportive of what she is asking for remedy for. They're also going to look at state bills. And so this is for any state. How do they measure what the care was? They look at the guidelines. They look at if there are any bills. California does, as we know, have some really strong bills for patient safety and patient pain. And then kind of the overarching is they ask, what would a reasonably prudent physician in a similar situation with similar training do? And that is where they go to evaluate, was that care appropriate? Did it meet the standard of care or not? And you always need a physician with the background of that specialty. So a pediatric doctor can't come in and say to the gastroenterologist, well, you did not do the surgery correctly. They obviously don't have the training and the specialty and the background to do that. So when those cases come up, that's how they evaluate the case. They look at guidelines, they look at state law, they look at what is called standard of care. Do they always do it correctly? No, but that's what they look at. Dr. Ibsen, do you have a comment, or no, you're just thinking? Okay. Then the second thing is what Monty mentioned earlier. If we get enough states to come along and to have guidelines that are positive, we are going to be able to change the narrative nationally. So we're starting to build momentum. There's already 8 states that have very strong bills. We're already starting to work on states getting strong guidelines. Maria is working in Washington. I went through the other day, Washington State, to look at the rules, and they are listening to her and changing the rules to be more patient centered. So yes, we're making some difference. And last but not least, should we be going after the DEA? Well, of course we should. Is that the best initiative for this group at this time? And the answer is probably not. The political situation right now is, I would call it unstable. It would be not impossible, but very difficult, I think, for each of us to coordinate with activities up against the DEA. Should we eventually do that? Well, that's something we can definitely look at, right? We're now an advocacy group, and we could certainly look at doing that. When Dr. Tennant and Red and I spoke, we felt a good place for this group to start, because a lot of us are new with advocacy, is the guidelines and the state board. You can get your hands around it, even if they're recalcitrant. It's easier for us to get to the state board. So will we at some point attack the DEA? I hope so. Probably not today, but one day I hope. Last question was, how do we work together? Already mentioned that on that list I posted, I yellow highlighted a person in your group who's probably more experienced than others and might be a good point person for you. For Alabama, Patrick O'Donnell has already volunteered. I volunteered for California. There's other, for Florida, Sarah Lewis has stepped up, and I just heard from Cora that Cora said she's willing to take a leadership role. Yay, Cora. And David has said he will take a leadership role in Arizona. And who else do we have that stood up? And as we go along, I'm sure more and more people will. And again, Maria for Washington. So little by little, we'll find people who will be willing to kind of coordinate the groups where there's more than one person. And it will be grassroots. It takes time, and we'll take people, messaging each other back and forth, but we'll definitely get there. Just going to take a little time. So, goals for the next meeting, and then I'm going to open it up for a little more discussion, is I would like you to actually look at your guidelines. Now you found them. So now the next step is to actually read them. And I want you to grade them like it was a school paper. So I want you to give them an A, B, C, D, or an F. And if they're like Maine and they don't have guidelines and what they're doing is horrifically inhumane, well, give them an F, for heaven's sakes. Probably do that for Montana as well. But read your guidelines. And I don't know if you remember, I gave you some criteria that might help. You can kind of do a gut reaction. That's fine too. But at the end of this PowerPoint, I've left some criteria that we talked about before. And since we have the time, I will go through it. So are controlled substances seen as a necessary element in pain management? If it starts off like Maine does and says, no soup for you, well, that they fail on that one. Are practitioners concerned about regulatory scrutiny addressed in those guidelines? Do they say, like California says, that they know it will be difficult and that they're trying to stand by the physician? Are patient treatment plans individualized? So in this case, the old guidelines in California did not do that, right? It would have allowed for Kaiser to do what they did, because what does a protocol do? What did the Kaiser force taper protocol do? It put all 50,000 pain patients in Northern California in one bucket and said, you will all be treated the same. There is one protocol. If you're taking pain medicine, you are on the protocol, period, end of story. That is not, there was no one got a free pass. Didn't matter if you were the caregiver for someone with dementia, if you had mental health disorders, if you had just had surgery, if you had small children, if you, like Shelley, had multiple chronic conditions, did not matter. You were in the same protocol. So looking at the old guidelines, we would have given California a negative on that one, which now, thank heavens, they've corrected to say it must be individualized. Does it allow the provider to determine dosage? This is essential. As we all know, so many of the laws and guidelines drank the Kool-Aid and took the CDC limits, right? Unbelievable. Actually codified the CDC guidelines into law. Even when the CDC said not to do it. Even when the CDC said not to do it. They codified them. Unbelievable. So make sure your laws and your guidelines have no limits. Hallelujah, right, Norm? Yeah, you bet. Does it correctly define physical dependence and addiction? Are we clear that they understand, right, the risk, that what is the true risk of addiction? What is the true risk of diversion? What is the difference between physical dependence and addiction? If those guidelines don't address those in their definitions, then they get a big negative mark. Does it avoid wording supporting the false narrative? And we've talked about the false narrative before. That's all the things we just talked about. Is it common for patients taking opioids to get addicted? Right? Do patients frequently get opioid use disorder? Right? Is that a big deal? Do they talk about opioid use disorder over and over again? And my favorite one is diversion. Do you know what the diversion rate is? Less than 1%. And most of that is from theft, right, Norm? Right? For pharmacies? We don't have, and
Yes, it
this
is.
is, yes, right? And this statistic is from the DEA. If you go to the DEA's last report on controlled substances, in their own document, it says diversion less than 1%. So why are we being penalized for diversion? Have no idea, right, Norm? No idea.
Exactly.
So
Exactly.
they got to take that out of there. Are patients involved in risk-benefit discussions and shared decision-making? This is my absolute pet peeve. All of these are important, but this is the one I just gravitate to. They must say in their guidelines that the patient will have a voice in decision-making. What other procedure or treatment do you go in for and they don't talk to you about it and give you some feedback and of some ability to respond? I mean, it's a cliche, but you always hear about the diabetic. Did they say to the person, oh, we're forcing you on metformin or insulin? Oh, it's an open conversation between the patient and the physician about treatment. And it should be no different for pain medication. So look at your guidelines and make sure that they have some kind of wording that says that decision-making is going to be done with the patient. The flip side of that is risk-benefit discussion. So the risk-benefit discussion is, what are the legitimate risks to this treatment? In this case, going on opioids. What are the legitimate risks? And please don't tell me diversion and addiction. What are the benefits, right? They should look at function, how well you're functioning. Are you able to get up and do the activities of daily living that you would normally do? And here's the one they always conveniently miss. What are the risks of you not getting pain control, right? They just somehow, it's like, we're not going to talk about suicide, overdose, all of the risks that you have blood pressure out up the ceiling. They're not going to talk about that. So when you say risk benefit, it's the risk of that treatment, it's the benefit of that treatment, and then there's the risk of not having that treatment at all. What happens if you don't do this? And last but not least is tapering addressed in a scientific and humane basis. There are times when the patient wants to taper and is ready to taper. And that's wonderful if that's where the patient is at that particular time. But it should be clear in the guidelines that that is a shared decision. And if it's done, it should be done slowly and with monitoring, and not like it was done to most of you sitting out there. I know. I would bet every single one of you out there was forced tapered in some manner, in some form, or your loved one was. And the biggest peeve for me with forced tapering is it's really nice. Well, not nice. In my book, it's mandatory. They should say that tapers may be paused. What would so wrong? So let's say the patient wants to taper. What would kill anyone if they say, well, the patient says to the doctor, I really want to do this. I would like to kind of get off, and I think I'm ready to, wean myself down a little bit, but I need a break. Could we stabilize myself at this dose? Do you think they will do it? No, they will not pause.
Sure.
In California, and you're going to get sick of me saying that, what did they allow? A pause. Yes. So Shelley, you're going to ram it down their throat. No tapers that are forced. You should allow, if you do, the patient needs to be involved, and you need to allow the patient to pause every single thing that Kaiser did. And
My doctor paused, doctor put a whole taper for a little over
yes,
8 months, and that's why she got shown the door.
yes, you had a doctor that
Eight fucking, months. Sorry.
That's okay. You had a doctor who fought for you. So Shell's doctor, original doctor, fought for her for 8 months and kept writing in the chart, you may not taper this patient. You may not taper this patient. And what did Kaiser do? Just move that
Show the
duck
door.
right on out the door. Do we know the exact details? No, but you can kind of figure, right? Doesn't take a
She
rocket
loved her
science.
job.
She loved her job.
She loved her job.
She
Here's
did
the
love her job. She was a wonderful physician. So we need to support those physicians out there, those that are brave enough to do what Shelley's doctor did for 8 months against the behemoth insurers that are out there with these ridiculous protocols that have just got to go. They've just, we're done. And all of you out there, I know you're struggling, but every one of you can make a difference. And I really take the time this next week. And if it takes you 2 weeks, that's fine. Take the time as soon as you can. Read your guidelines, read your state laws, and grade them, right? And then post those for me if you can, if you're up to it, on DocToks, or the next time we meet, you can put it in you can put it in chat, right? Whatever works for you. Just somehow let me know what you found with the grading.
Here's
Okay?
something that's critical that I want to make a comment when we deal with tapering. A question then becomes, why taper at all? I mean, first of all, tapering is a medical procedure. And
Yes.
tapering, and I want people to understand it, tapering for dependency for a person who's dependent is totally different from tapering from addiction. Okay? And so why the question is what why if we're going to talk about tapering a medical procedures, well, let's say we need to taper somebody from insulin. Well, what's the justification? Well, you can get heart disease, you can have kidney disease and stuff like this. Then we have another, I just want people to think about this, about there's no science behind tapering is an aesthetic issue, not a medical issue. And most importantly, we talk about these pharmacists. And I have to, Mark Gibson, Dr. Mark Gibson is at war with the pharmacists, and he needs to be. And I'm at war with them too. And I'm a pharmacist and a dentist. The question I always, and I talk to my friends, when they come in and say we need to taper you off, I don't feel uncomfortable filling this prescription. I always come back to one bottom line question. Okay, what's your level of expertise? And put it in writing. Have them put it in writing as to why they are, here's the question, withholding treatment. Oh, holding treatment and on what basis and what level of expertise do they have over the
To do that.
prescribing physician? And here's another trick too. They always, this is all about medical. But you ever anybody says withholding treatment from the, I always ask, well, then what happens if I come in with a tooth? And they always say, well, I want to look at the radio, I want to look at the X-rays and all that kind of stuff. I always say, so what happens if I said I had a patient that needed a endodontic procedure on tooth number 14, and we had an extra a mesial buccal canal, A and B. Would you want to see those radiographs? And and then ask them, do you know how to read those radiographs?
Minor detail.
Well, and then there's the key. And then this is the other thing we talked about, the DEA. Our little group has challenged the DEA, and and clearly they have what we found is that it's not the DEA, but it is the prosecutors that simply come in and make up stuff, and it's when it all costs. It is uh, uh, depend on these so-called, they're not experts, but they're grifters, and those sort of things. And one more comment you made about uh, the level of expert. One must be a gastroenterologist versus a uh, oncologist or a pediatrician. And the same thing, what level of expertise does a pharmacist have to deny a patient with whole treatment and not have conducted a physical examination of that patient, not having looked in that patient's, looked at any radiographic information, MRIs, not taking the assessment. And again, I go back and not put it in writing. And this is what causes Mark Ibsen, Dr. Ibsen, to blow up. I mean,
Yeah.
he goes at.
And
So
Norm,
I'll
what
leave it
you
there.
just, if I can interrupt, Norm, I've heard Dr. Ibsen say the pharmacist has a corresponding responsibility, but they also have a corresponding accountability. If
Liability.
they're going to be in that position, then yes, do they know the patient? Do they know
Absolutely.
their history? Do they know, along with this lovely responsibility,
Right.
corresponding, comes accountability, and somehow that's gotten lost in translation. So that's probably something, yeah, that's definitely something we need to look at. Norm, I'm going to turn it, we got a couple other questions. I hate to switch.
Okay.
Brandon, you've been having your hand up. What you got?
I want to point out what Doc Norm and Marcus was saying. My pharmacist would literally step out behind the desk and go into the room and shut the door. And they'll fill my medicines, no problem. But I'm catching on for the past 5 or 6 visits. She will literally walk away from the computer and walk into the break area. It's a small mom and pop pharmacy. Her grandfather birthed me. Her father was my pharmacist. And she cannot live with the fact that what they're doing, she knows this. And I think this is why she walks away, because she cannot put it on her heart.
Mhm.
So
That's
they'll exit and walk away. Because I've had an incident there. And I seen this earlier today about medicine going missing. Count your medications at the counter, especially when you see somebody go bonk.
Oh.
Well, that brought up an eyebrow. So I poured them out in my hand. And this is her exact words. If you had walked out that door, that'd been my word against yours. Well, she no longer works there. They shorted me 30 tablets.
Yeah, you do have to be really careful with that. Thank you. Thank you, Brandon. I do want to cover one last thing, and then we have 5 more minutes for questions. So the last thing before we leave is Red has Dr. Lawherd, PhD, has never asked anything of us before. He writes and writes and produces and has never asked anything of us. Well, he has a request, and I want to honor him and make sure we get this out. So this will be in the paperwork that you're going to get. He just developed the most amazing webinar for physicians about prescribing the right way. They get CME, continuing medical education, for taking this course. And on the surface, it seems like, wait, what is he doing? It's about the CDC guidelines. And you're going to say, Red, have you lost your mind? What is going on? But if you listen to this webinar or read the narrative from the webinar, he has carefully crafted piece by piece of the CDC guidelines, what's wrong with each piece and how the doctor on the ground can salvage it. And he got this group. It is being produced by the DC Department of Health and Health HIV, a huge organization. And not only does he have this CME, but he's been invited to speak this fall at the Health HIV conference. So yay for Red. We're so proud of him and the work he has done. Yes, yes. So when I give this link for the CME, it's not just for doctors. So nurses can get credit. So every year, nurses, doctors, pharmacists, psychologists all have to take continuing medical education. So when you get this link, what he's asking of us, please share it with your doctor. Please share it with your nurses. Please share it with your psychologist, whoever, whatever clinical person you've got, and tell them it's so they can sit back and watch the webinar. It's an hour long. And then to get credit, just like anything, you answer a few questions at the end, and then you get
Yeah.
your CME. of all the things he's done for us, if we can do this one thing for him, I think that would be really terrific. So please help me when you get this in just spreading the news about his education course that he developed. Thank you so much. Okay, and Jamie, I'm going to open it up for 5 last minutes, and then I think we'll call it a wonderful session. Right, 5 more minutes. Any last comments or questions on the advocacy initiative, on what you're supposed to do with the guidelines or anything else?
I wanted to point out something when I tried, and our group, You're Within the Norms, to write each individual's effort, sacrifice here. We wrote an article about Jamie the other day, and I'd like those folks. I owe Carol, I think it's Bennett, one. She needs to send me her information. We try to highlight people who have really have been what we call the warriors, the what we as Antonio Grimm's, the organic intellectuals, the people who have gained knowledge and fought this issue. So we tried. Mark Ibsen is one of the folks we've highlighted. Steve, um, uh, a wonderful Steve. Yeah, I can't. Well, anyways, uh, and so and Red Lawhorn, his article. So what we and Bob Sheeran, and I've got two that we're still working on with Bob Sheeran, but these people need to be, their efforts. It's like a multi-force operation. We have to come in from the air, the sea, with our cruise missiles and all this kind of stuff, and focus attention on the atrocities that have been taking place here, where people have been denied healthcare, and criminalized on top of it. And we've had physicians that are being sent to prison for doing exactly what they've been taught to do in their medical school and dental programs. So, excuse me, I have an allergy. But anyways, these are some of the things we do at you're with the norms.com, and try to, and again, be an advocate. And we are not afraid to take on the DEA or these prosecutors and their pattern of injustice throughout the world. And we have had a dramatic effect on that, on the DEA and the way they and their behavior. We've called it out. And I just hope that we can, or not hope, but this group, it's essential that we carry through with this mission that we have here, and exposing this justice.
Norm, thank you so much.
Yeah,
We're going to need to wind it up here, Norm. Thank you so much.
Oh, I didn't mean to take all the time.
Good to hear. So we look forward to seeing you next week. And there may be a guest next week. We don't have details, but fingers crossed. Jamie's working really, really hard on that. So everyone have a wonderful holiday. Thank you so much for coming on the day before your holiday starts. I appreciate everyone so much and look forward to working with all of you. Okay. Good night, everybody.
Good night, everyone, and have a happy and safe 4th of July celebration. And just hug somebody if you can. And if you have nobody to hug, make sure you just hug yourself, because you're worthy of that. You're worthy of your own love.
Yay.
We love you. You're not alone. We're here for you.
Absolutely.
Not
Good
at
night,
all.
everybody.
God save the pain warriors.
Yes.
Amen.
Amen.
Love you guys.
Love you too.
Love you.
Love y'all. Night.
Night.
I'm here for everybody.